Hello, everyone. Welcome to Rehab Podcast Weekly. The topic today is spasticity, assessment, and intervention.
You know that feeling, right? When your muscles just feel stiff
Hmm.
or they twitch when you don't expect it?
Yeah, that lack of control.
Exactly. So today we're going to unpack something related but, well, more complex. Spasticity.
Hmm.
It often comes up after damage to what doctors call the upper motor neurons. Things like stroke or cerebral palsy can be involved.
Right, those are common causes.
And for this deep dive, you, our listener, sent in a really great set of sources. Super interesting stuff.
Oh, yeah. What do we got?
Well, there's a clinical study looking at, what it's actually like to live with spasticity day to day.
Okay, the patient perspective.
Crucial, definitely. Then a review on how doctors assess it, especially in kids with cerebral palsy. Also, a protocol, like a plan for looking into drug treatments for MS-related spasticity.
The management side. Good.
Yeah, and a big meta-analysis on spasticity after stroke, how common it is, risk factors. And finally, some resources just defining it and explaining the assessment tools.
So quite a mix. Clinical experience, assessment methods, treatment, prevalence. Nice overview.
Totally. And our mission today is basically to give you a solid handle on spasticity, what it is, how it impacts lives, how we measure it, how we manage it, get the key stuff without getting lost in the weeds.
Sounds good. It's fascinating how these different viewpoints, the person living with it versus the clinician measuring it versus the researcher studying treatments, how they all fit together or sometimes where the gaps are.
Exactly. So let's start right at the beginning. What actually is spasticity, fundamentally?
Okay, so the sources point to that upper motor neuron issue we mentioned. Think of them as the brain's messengers telling muscles what to do. Damage there disrupts the signals.
Right.
And specifically, it messes with the reflexes, particularly the tendon stretch reflex. It sort of loses its inhibition, becomes overactive.
Okay, overactive reflex. And is that different from clonus? Because sometimes people mention both.
Yes, good distinction. Spasticity is more about that muscle tightness, that resistance you feel when you try to move a limb passively. And importantly, it's velocity dependent, meaning the faster you try to stretch the muscle, the stronger the resistance or the catch you feel. Clonus is different. It's more like those rhythmic, uncontrollable muscle jerks or beats you might see, often at the ankle or wrist.
Got it. Tightness versus jerking. And has the definition of spasticity itself changed over time?
It has, actually.
Yeah.
Lance's original definition, back in the day, really zeroed in on that velocity-dependent increase in tone and those exaggerated reflexes. Quite specific.
Okay.
Then Pandian broadened it out a bit. He saw spasticity as just one symptom, one positive sign of the whole upper motor neuron syndrome, basically framing it as a disorder of how the brain senses and controls movement, a bigger picture view.
Sensoromotor control. Makes sense.
And more recently, Dressler proposed defining it as involuntary muscle overactivity that happens because of passive movement or even just sensory stimulation, like touch.
Interesting. So it's becoming a more kind of functional definition almost, less purely about the reflex and isolation.
Exactly. It reflects a growing understanding that it's not just one simple mechanism.
Which really fits with that study on the lived experience, right? Because the people in it, they weren't just talking about reflexes. It affects their whole day.
Absolutely. That study is so powerful. They talked about how spasticity wasn't just constant, it fluctuated. It seemed to have a rhythm.
A rhythm, like predictable times?
Yeah, linked to their daily activities, maybe even their biological clocks. Someone actually said, in the morning when the aids are turning me over, those are when I'm going through my worst spasms, then in the middle of the night and late in the afternoon.
Wow. So it ebbs and flows, not just always on.
Right, which highlights how vital it is to listen to what patients report, not just what we see in a snapshot assessment.
And they linked it directly to just basic daily stuff, didn't they? ADLs, activities of daily living.
Oh, absolutely. Things we totally take for granted, like getting dressed, getting out of bed. They described needing enormous energy just to fight against their own muscles.
That sounds incredibly frustrating.
It does. One person put it really well, something like, spasticity should be termed as any involuntary muscle movement that interferes with a person's daily living. And that is the exact opposite of what they tell their body to do.
The exact opposite. That really captures it.
Yeah. And think about the impact. Even simple touch could sometimes make the spasticity or clonus worse.
Oh, wow.
Which made them feel helpless and even scared of accidentally hurting their caregivers during personal care. Someone said, I'm always afraid I will kick whoever getting me up and stuff.
That's awful, feeling like your own body might harm someone trying to help you.
Yeah, and it led to this feeling that maybe sometimes caregivers didn't quite get it or they were rushed.
Rushed.
Yeah, there's a quote like, a little more patience. I think they lack a lot of patience, some of them, not all of them. A sense that care opportunities were being missed because things felt hurried.
Which, when you think about patient-centered care, that's fundamental, right? Taking the time, understanding their pace.
Exactly. And this wasn't just about ADLs. It limited their overall movement, their mobility. It meant more dependence on others and a real fear of falling. That phrase, out of control feeling, came up.
Understandable. And it's not just physical, is it? The study touched on the emotional side, too.
Big time.
Hmm.
The frustration is obvious, but also fear, anxiety. And the difficult part is that stress and negative emotions could actually increase the spasticity.
A vicious cycle, then.
Pretty much. Someone noted, once I get stressed, or if there's a lot of stuff going on, my tone will automatically increase. So they talked about needing coping mechanisms like meditation or prayer, trying to manage that mind-body connection.
And were there other factors that made it worse? Physically?
Yes, comorbidities were mentioned. Things like urinary tract infections, UTIs, could significantly ramp up spasticity and clonus for some people.
Really? A UTI?
Yeah, one participant described that experience quite clearly. It shows how interconnected everything is in the body.
Definitely. The study also mentioned something about communication issues with doctors.
Right. Sometimes the medical language itself was a barrier, like the terms complete versus incomplete spinal cord injury. One person had interpreted these in a way that was quite different from the clinical meaning, which caused confusion and maybe some mistrust.
I could see how that could happen. Medical jargon can be tricky.
Totally.
Yeah.
And it fed into this desire participants expressed for more sort of holistic and individualized care. They wanted doctors to really listen to their descriptions, maybe explore alternative therapies.
Valuing their experience as much as the clinical signs.
Exactly. One quote was about wanting doctors to give their patients options and strategies based on what the patient says versus what is happening clinically. And another mentioned exploring natural medicine. It's about partnership and options.
It really paints a picture of how deeply personal this is. Okay, so that's the lived experience. How do clinicians actually try to measure or assess spasticity? Let's shift to that review on kids with cerebral palsy.
Okay, so that review breaks down the methods into two main camps, subjective and objective.
Subjective meaning based on the clinician's judgment.
Pretty much, yeah.
Correct.
Using standardized scales, but still relying on observation and feel. The most common ones are probably the Modified Ashworth Scale, or MAS, and the Modified Tardieu Scale.
Right. I've heard of the Ashworth scale. How does that work, roughly?
With the MAS, the clinician moves the patient's limb passively and rates the resistance they feel on a scale, usually 0 to 4. Higher score, more tone.
Okay, straightforward. And the Tardieu?
The Tardieu is a bit more nuanced. It tries to capture that velocity-dependent aspect. The clinician moves the limb at different speeds, slow and fast, and notes the angle where they first feel that catch or resistance that's called R1. They also measure the full available passive range of motion, R2. The difference between R1 and R2 gives an idea of the dynamic component of the spasticity.
Ah, okay, so it tries to separate out the spasticity bit from just, say, a tight joint.
Exactly. And there are other subjective tools, too, like patients rating their own spasticity on a numeric scale, or specific tests like the Eli test for the thigh muscle, or broader tools like the hypertonia assessment tool and the Australian spasticity assessment scale.
Lots of options. But being subjective, I guess the downside is consistency. Like, would two different clinicians get the same score?
That's the main limitation, yes. They're relatively easy to perform, don't need fancy equipment, but they do depend on the examiner's skill and interpretation. Reliability can be an issue.
Okay, so that brings us to the objective methods. What are we talking about there? Technology.
Often, yes. Trying to get quantifiable data.
Yeah.
Electromyography, or EMG, is one recording the electrical activity in the muscles to see when they're firing inappropriately.
Like during a passive stretch.
Exactly. Or looking at reflexes like the H reflex or Hoffman's reflex to gauge how excitable the spinal cord pathways are.
Any others?
Yeah, there are newer techniques using ultrasound, like acoustic radiation force impulse elastography or real-time sonoelastography. They basically measure tissue stiffness, which can relate to muscle tone.
Ultrasound to measure stiffness. Cool.
Yeah, it is. And then there are biomechanical approaches using sensors to track movement precisely during passive ranging. Or tools like the pendulum test, which looks at how freely a limb swings. Sort of like a pendulum. Less swing means more resistance. There's also a stiffness tool called LSDIF used with robotic gait trainers.
So lots of tech trying to get hard numbers. What are the catches there?
Well, while they give more detailed objective data, they have their own issues. EMG, for instance, is usually best for surface muscles, might miss deeper ones. Elastography can be very operator-dependent, requires skill to get good readings. And of course, the equipment can be expensive and not available everywhere.
Right. Not practical for every clinic.
Exactly. So the review concludes that we still need better, more reliable, and standardized objective methods that are also practical for clinical use. There's still work to do there.
Okay, that makes sense. So we know what it is, what it feels like, how it's measured. Let's talk management. How is spasticity actually treated? That nice protocol for MS gives some clues, right?
It does. It focuses on the pharmacological side, the medications. It lists several main categories.
Like what?
Things like baclofen, which can be taken orally as a pill or delivered directly to the spinal fluid via an implanted pump. That's intrathecal baclofen.
Ah, okay. Different delivery methods.
Right. Also tizanidine, gabapentin, dantrolene sodium, benzodiazepines, drugs like diazepam or clonazepam.
The benzo family.
Yep. Then botulinum toxin injections, Botox directly into spastic muscles. Pregabalin is another one. And phenol, which is sometimes injected near nerves to block signals, or used intrathecally too.
So quite a range of drug options working in different ways.
Exactly. And the protocol emphasizes that when reviewing treatments like these, the best evidence comes from randomized controlled trials, or RCTs. That's the gold standard for seeing if something truly works.
Makes sense. But it's not all about drugs, is it? The sources mention other approaches too.
Absolutely not. Non-pharmacological strategies are huge. Stretching came up again and again across the sources. It seems to be a real cornerstone of management.
Just regular stretching.
Seems so. Also, managing the environment, keeping things calm, minimizing sudden loud noises or excessive touch, given how sensory input can sometimes trigger spasms.
Right, like we heard from the lived experience study.
Exactly. Warm water therapy was also mentioned as potentially helpful for muscle relaxation. And there was acknowledgement of alternative approaches people might explore, like acupuncture or herbal remedies, though the evidence base might vary. Plus, those mind-body things like meditation.
And what about technology beyond assessment, any treatment tech?
Yes, neuroprosthetics were mentioned, specifically functional electrical stimulation, FES.
FES, how does that work?
Well, one example given was for foot drop, where the foot drags during walking because of spasticity or weakness in the calf or shin muscles. FES can be used to electrically stimulate the nerve controlling the muscle that lifts the foot, the peroneal nerve activating the anterior tibialis.
So it triggers the muscle at the right time when walking.
Exactly, during the swing phase, to help clear the foot.
Yeah.
It's used for that dynamic equinus foot deformity.
Interesting. Is that the only option for foot drop?
No, botulinum toxin injections are also used for that, targeting the overactive calf muscles, like the gastrocnemius and soleus. Sometimes they even target the posterior tibialis muscle, maybe using EMG or ultrasound to guide the needle precisely.
Okay, so it really depends on why the foot is dropping.
Precisely. The sources stress the need to carefully assess the gait, figure out if it's a dynamic issue happening during movement because of spasticity or a fixed contracture, where the joint is just stuck. The treatment's different.
Got it. Okay, one last area, spasticity after stroke. That meta-analysis looks specifically at that, right? How common is it?
Yeah, they looked at a lot of studies. The prevalence, like how many people have it, actually varied quite a bit in the data, reported anywhere from around 4% up to nearly 43% of stroke survivors.
Wow, that's a huge range. Why so wide?
Differences in study methods, when they measured it after the stroke, how they defined it. Lots of factors. But a key finding was that it was significantly more common in stroke patients who had paresis muscle weakness.
Okay, so weakness is a big clue.
Seems like it. The analysis identified moderate to severe paresis, along with sensory problems after the stroke, as risk factors, meaning those patients probably have a higher chance of developing post-stroke spasticity, or PSS, and maybe need closer monitoring.
And when does it typically show up after a stroke? Is it immediate?
Not always immediate. The analysis found about half of patients seem to develop it within the first month. But again, there's variability. It also suggested that for moderate to severe strokes, the spasticity tends to sort of stabilize within about 30 to 90 days, 1 to 3 months.
Okay, so there's a window where it develops and then might level off somewhat?
Seems to be the pattern often, yeah. But the review also circled back to the assessment issue.
The modified Ashworth scale again.
Yeah, pointing out its limits. It tells you about resistance, but not really why there's resistance. Is it purely the velocity-dependent spasticity, or is there joint stiffness or other factors?
Yeah.
Can't easily distinguish those components.
So, same conclusion, really need to combine clinical feel with other, perhaps more objective methods for a full picture.
Exactly. That was a consistent theme.
Okay, wow, we've covered a lot of ground. So for you, our listener, let's try and boil down the key takeaways from this deep dive.
Oh,
First, spasticity isn't just simple muscle tightness. It's complex, stemming from that upper motor neuron damage, and it's often velocity dependent. It's also distinct from clonus, those rhythmic jerks.
right. And second, the lived experience is absolutely crucial. It impacts everything: daily activities, mobility, emotions, sleep, and it fluctuates,
Yeah.
often influenced by things like stress or even time of day. It's deeply personal.
Definitely. Third, assessment is tricky. We have subjective scales like Ashworth and Tardieu, which are common but have consistency issues. And we have objective methods using tech like EMG and ultrasound, which offer more detail but have their own practical limitations.
Yeah, finding the right balance there is key. And fourth, management is multifaceted. There are various medications like baclofen, Botox, and others. But non-drug approaches are vital too: stretching, managing the environment, therapy, maybe FES for specific issues like foot drop.
It really highlights the need for an individualized approach, doesn't it?
Absolutely, and that connects to why this matters. Understanding spasticity from all these angles is so important, not just for the person living with it, but for their families, their caregivers, the doctors, the therapists, everyone involved. It's about providing effective care, but also compassionate care that recognizes the individual's reality.
And clearly, there's still progress to be made, refining assessments, developing even better, more tailored treatments.
For sure. The field is definitely evolving.
So here's a final thought to leave you with, something to mull over. Given everything we've heard, especially about how personal and varied the experience of spasticity is, how can healthcare really evolve to better weave those individual patient stories and perspectives right into the core of diagnosis and treatment, moving beyond just the clinical checklists and scales?
That's a big question. Or maybe, looking ahead, with all the tech advancements we touched on in measurement, in things like neuroprosthetics, what kinds of innovations are on the horizon? What could truly revolutionize assessment and management to make a significant difference in people's day-to-day lives?
Edited by Min.Rehab. Thank you all for listening, and see you in the next podcast.